Hello guys, welcome to Podcast Met. In this audio podcast, I'm going to be saying about gynecological history. There is nothing very special about gynecological history. It is very similar to obstetric history and normal medical medicine history. So here, before listening to this gynecological history, please refer to the obstetric history that I have already uploaded, and I will be using most of the things from the obstetric history here. So please refer to that and come back here. So coming to the gynecological history, normally like for any other history, will be taking demographic profile of the patient. That is name, age, residence, socioeconomic status, education status, husband's name, occupation, etc. So all of this we will take. Then coming to the chief complaints. Chief complaints in gynecological history may be abnormal menstrual bleeding or abnormal uterine bleeding, it is called. It can be abdominal pain, lower abdominal pain, abdominal lump seen, and infertility, amenorrhea, hirsutism, urinary and sexual problems, vaginal discharge, pelvic organ prolapse, etc. All of these can be the chief complaints in gynecological history. And coming to the history of present illness, we are going to expand all the above chief complaints in this. We are going to say about duration, onset, progression, aggravating factors, relieving factors, associated symptoms relating to this above chief complaints. So after history of present illness, we are going to ask for past history. Past history में so many things will come, like diabetes, hypertension, obesity, endometrial carcinoma, thyroid issues, STDs, PCODs, all of these comes under past history. And we'll also ask for past medical histories, like any fever, infections, any hospital admissions, etc. There is if there are any history of previous surgeries, is there any uptake of medication, etc. OCP use, Kani. All of these we'll be asking. Then coming to the menstrual history, there is menstrual history next. Like all the other menstrual histories we take, we will ask for age of menarche, post and present menstrual cycles, like past and present menstrual cycles, if they are regular or irregular, how many days cycle and how many days bleeding will happen, if there is any dysmenorrhea, if there is any irregularity in the periods, etc. We'll be asking in the menstrual history how many pads a day will take, like that. And then coming to the obstetric and marital history, we'll be asking about age at marriage, first sexual intercourse, obstetric score, obviously, GPLA score, lady score, whatever it may be, details of all the other previous pregnancies, current sexual activities if she's involved in any, or frequency of sexual intercourse, if there is any contraception used, multiple sexual partners, and different sexual partners, etc., like that. And then we'll be asking about family history, like generally like in medicine, and personal history generally like in medicine. And then coming to the examination, here in examination we'll be seeing for all those general things that we see in medicine, like build, nourishment, patient conscious, coherent, cooperative, like the normal general medicine thing, head to toe examination, all the vitals we'll be taking, etc., etc. And here comes in GP, two more things are very important, that is breast examination and thyroid examination. Those in particular we have to do it nicely. Then after GP, we'll go for systemic examination. Systemic examination, all the other we'll do like what we do in OBS, like that. But we should be more thorough in GIT examination, like per abdominal examination, that is inspection, palpation, percussion, auscultation. All of those in detail we have to do in systemic examination in gynecology. Then after that, we are going to do pelvic examination. Under pelvic examination, there is examination of external genitalia, speculum examination, bimanual pelvic examination, rectal examination, rectovaginal examination. Then after that, there is diagnosis, plan of management, investigation, treatment, etc. So under abdominal examination, in inspection, we are going to look for any masses or distension, umbilicus, any scars seen, sinuses, dilated veins, hernial orifices, visible palpitation, visible palpitations, etc. In palpation, we'll be seeing for any tenderness and non-tender areas. We'll be seeing for any masses palpated for following features like sight, size, shape, surface, border, consistency, tenderness, etc. All of these we'll be seeing. In percussion, we'll be seeing for ascites. Ascites, particularly in malignancies of that is malignancies like fibrosarcoma, Brenner's tumor. Brenner's tumor is not a malignancy though, but it can be like it will present with malignant ovarian tumor, Meigs syndrome. All of this presents with ascites, so we'll have to do percussion also properly. And then there is shifting dullness, etc. Parietal examination will do because in malignancies there can be malignancy metastasizing from this region to the rectal region, so we'll do per rectal examination. And also for endometriosis, because there might be occurring of uterosacral ligaments to the rectum. And after that we'll be giving the summary provisional diagnosis, plan of management, etc. like that. This is what is about gynecological history and examination. Nothing very special about it. It is mostly like that of medicine. And one more point which I want to add here is abnormal uterine bleeding causes. It is palm coin. It is abbreviated as palm coin. Under structural causes, there is PALM, that is PALM, that is P, polyp, A, adenomyosis, L, leiomyoma, which can be submucosal, mucosal or other, and M, which is malignancy and hyperplasia. Coming to the non-structural causes of abnormal uterine bleeding, it can be coagulopathy, that is COIN, COEIN, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not yet defined or not yet identified things. All of these are the causes of abnormal uterine bleeding. I just wanted to say that. That is it for this gynecological history and examination. Thank you.